My name is Leena. I'm a student at the University of Pennsylvania, a part of their MPH program, and this past year, I worked on a project exploring the impact of race on IPV screening at the emergency department of a Metropolitan Pediatric hospital. IPV, or intimate partner violence, affects 1 in 4 women and 1 in 10 men, and the Pediatric Emergency Department is an ideal location to screen for and address IPV. This is because IPV victims may be more likely to seek care for their children over themselves, and also high volume of patients seeking care in the ED provides an effective way to reach a large population. Previous literature has found that white women are more likely to screen positive for IPV. However, other studies have found that racial minorities are more likely to experience IPV. We know that racial disparities exist in other forms of screening, such as for child abuse. Therefore, we were interested in exploring the impact of race on the IPV screening program at the Children's Hospital of Philadelphia. The screening process at CHOP involves a nonverbal screen completed by providers during the triage and rooming process. A screening card shown in image 1 is given to caregivers, and the screen can be documented by providers as completed, as in a screening card was given to caregivers, or deferred, as in a screening card was not given to caregivers. For deferred screens, a reason can be documented. Possible reasons include that multiple caregivers are present, no caregivers are present, there's no screening card available in the room, or other. The objectives of the study were to determine whether or not there are racial disparities in screening for IPV in the CHOP ED, and to explore provider experiences in screening for and addressing IPV. We designed a mixed method study that first involved extracting screening rates, documentation rates, and patient rates from January 2016 through December 2020 via our ClickView data analytics software. We then used a chi-squared analysis to compare rates and patient race. We followed this with semi-structured interviews with ED nurses, nurse practitioners, and attending physicians. The interviews explored thoughts on risk factors associated with IPV, provider bias when addressing IPV in the pediatric ED, and reactions to aggregate screening data. Participants were recruited via email, and interviews were recorded and transcribed. For our quantitative results, we first compared screenings completed versus screens that were deferred, and we found that caregivers of Black and African American patients were more likely to be screened compared to caregivers of white patients. We then looked at the screens that were deferred and compared screens that were deferred with documentation, as in screens that were deferred with a documented reason as to why, with screens that were deferred without documentation or without a documented reason as why. We found that caregivers of Black and African American patients were more likely to have no documentation when the screen was deferred as compared to white patients. We conducted 7 interviews so far, but we did not code them because we did not elicit sufficient interview responses. Therefore, we instead reviewed our transcripts and revised our interview guide. Image 2 is an example of 2 questions that were updated in our revised interview guide. We removed jargon and simplified our questions, and we plan on resuming our qualitative interviews next month. In conclusion, we did find significant differences in screening and documentation rates based on race. It is possible that knowledge of disparities in IPV experiences may lead to provider bias in screening. For example, providers may screen caregivers of Black and African American patients more because previous literature shows that minorities are more likely to experience IPV. On the other end, providers may hesitate to screen Black and African American caregivers because of previous literature that states that minority children are more likely removed by CPS due to suspected abuse. We hope that our qualitative interviews will be able to shed some light on the role that race may play in providers' ability to screen for IPV in the pediatric ED. Our study does have a few limitations. First, our study has a convenient sample of interview participants. Therefore, our results cannot be representative of all providers in the ED. Second, only patient race is documented. Therefore, a study runs on the assumption that the caregiver is of the same race as the patient. Despite this, our study shows that disparities do exist in IPV screening and that there is a clear need for more research on the subject. I'd like to thank my team at the Children's Hospital of Philadelphia and also my professors at the University of Pennsylvania for helping me design and implement this study. Thank you for listening to my presentation.